Okay, so today we're going to be doing part 2 of the gas exchange, so covering pneumothorax, chest trauma, and there's some chest tubes in there as well. Okay, so pneumothorax, what is it? Right. Obviously, remember we do the what is it, how do we treat it, and what do we teach them. So with pneumothorax, it's the same thing, right? So we have 3 different types of pneumothorax. You can have a simple, a trauma, or a tension, right? So simple pneumothorax is a bleb, all right? A bleb, like a little piece, a little lung cyst, if you will. So that's why they call it a simple one, because usually they're pretty small. And sometimes if the blood ruptures, it can allow air into the pleural space. So that's how they get a simple pneumothorax. A trauma is when air escapes. Okay, so this is like an open chest wound. So think laceration, a bullet. Okay, and this is going to cause what we call a sucking chest wound. And this is going to often be accompanied by a hemothorax. So trauma is considered an open pneumothorax, right? Versus tension, which is what we see the most, and tension is what we call a closed pneumothorax. Right, so this is when the air is drawn in through the injury of the lung or the chest wall and it cannot escape. So you're having all that extra air putting pressure on the thoracic cage, putting pressure on the heart and the vessels, causing that lung to collapse inside the thoracic cage. And this is really where you're going to see that tracheal shift. Right? So if you have that closed tension pneumothorax, you're going to have that tracheal shift to the unaffected side because of all the air pushing up on the side of the pneumothorax. Okay. Some causes for simple could be associated with lung disease, severe emphysema, trauma. Obviously, we talked about. Think of the trauma as an open trauma, so lacerations and guns. And tension is usually caused by COPD, asthma, can be caused by trauma, so like blunt force trauma to the chest, can be caused by CF, tuberculosis, so all kinds of things can cause tension, and sometimes they don't have a cause. All right. So what we expect to assess in a client who is having a pneumothorax. And so obviously it depends on the kind, right? If you have a simple pneumothorax, the trachea is probably going to be midline. You might see some chest expansion decrease, obviously diminished breath sounds, and depending on the size of the bleb, you could even have absent breath sounds. Right. For tension, you're going to see that tracheal shift to the unaffected side. Going to have decreased chest expansion again, and they might have a fixed or hyper-expanded state, and the breath sounds are going to be diminished. Right? So for tension, remember it's all that extra pressure on one side. So you're going to have almost like a barrel chest, but on the one side, and definitely that tracheal shift. Okay, so for both simple tension and trauma, all 3 of those, you're definitely going to see signs of air hunger. Right? So diaphoresis, anxiety, restlessness, shortness of breath, decreased blood pressure, increased respirations, increased heart rate, and in the later stages, cyanosis. Right? So cyanosis is no good. That means we're too late. Right? So some diagnostic tests. We could obviously do an X-ray. We're going to look at ABGs, and some physicians might get a CT scan. So how do we want to treat this? So medical management, they can do a thoracentesis. Right? So in thoracentesis, this is when they have a needle aspiration. So they might go in and drain pleural effusions if that's what's causing the pneumothorax, and that'll help restore the pressure. Okay. Chest tubes are the most common way we fix pneumothorax, especially those tension pneumothorax. It's just built up air. So usually it's, again, inserted into the pleural space, although you can have chest tubes in the sternal cavity, and usually that's for like cardiac surgeries. And then, of course, thoracotomy. This is the opening of the chest wall surgically, and typically done if they already have done a thoracentesis and they have a ton of fluid that came out. So usually that line would be like 1,500 mLs. If they have more than that, then they can do that thoracotomy. So again, opening that chest surgically to release the pressure and drain more fluid. Right. So some of your nursing interventions, the patient might be on a high concentration supply of O2. Okay, so if they're hypoxemic, they are going to have those maybe a Venturi mask, high flow nasal cannula, maybe even ventilated depending on how bad it is. Definitely going to be looking at pulse ox, looking at breathing, airway, and of course we're monitoring that chest tube. So here is a pretty picture of your chest drainage system. I'm going to talk a little bit more about those. You can see on the picture of the right that they have drainage collection chambers, they have an area for a water seal, okay, and then it shows you where exactly in the cavity that they might be inserted. So there's two types of drainage systems. We have a wet and a dry. Okay, so for a wet drainage system, they use the water seal to prevent air going back into the chest on inspiration. Okay, so usually the amount of suction for the wet ones are determined by the amount of water that they put in the suction chamber. Okay, so then you would obviously see bubbling for the wet, right? So, if you think about bubbling and air being in the lungs, that's normal for a wet one. And in fact, that means the amount of bubbling that we have, that would indicate the strength of the suction. So the more bubbling, the more suction we have. Right? Wet ones are usually a common one that you'll see. Right? In the dry systems, this is more of a one-way valve. So the suction control dial is that machine. Okay, so instead of having that water seal, it's going to be hooked up to your wall. Right? Both systems we can operate for gravity. So you're going to want to put the chest tube, of course, with gravity, so near the floor, so almost like a Foley. Okay, you want maybe try to hang it from the side of the bed. If they have to stand on the ground, try to tape the actual chest tube container to the floor so it doesn't tip over. And if you have a system disconnection, air can go into the pleural space, and that can actually cause a worsening or other pneumothorax. So we have to be really careful with the tubing in these. The nursing management, besides keeping our connection, we're going to look at drainage, looking at color, looking at amounts, definitely patency of the system, making sure there's no clamping, kinking of the tubes, and of course, like I was already talking about, we want to keep that system below chest level. Alright, so that was kind of the quick and dirty on pneumothorax, but I did want to actually go back, if I can, see if I can go back here. Oops. I also wanted to add for the chest drainage systems, if you do in fact or become disconnected, if the chest tube becomes disconnected from the actual container itself or the patient, you want to put that open end of the chest tube in a bottle of sterile water. And so we do want to keep it nice and sterile because it is a closed system. Okay. So moving on from pneumothorax, we're going to talk a little bit about what can cause those pneumothorax, and that's with chest trauma. Right. So what is chest trauma? Obviously, it's trauma to the chest. Right. You can have 75% of all trauma deaths are related to chest trauma, and not necessarily because of someone's complete chest being crushed or shot or anything like that, but it's usually from the complications that happen with the chest trauma that we're going to talk about. So we have two types of chest trauma. We can have blunt and penetrating. Okay, so the blunt traumas usually result from a sudden compression or a positive pressure inflicted in the chest wall. Okay, so that can even mean too much pressure inside the thoracic cage. So think of things like, excuse me, barrel chest, okay, or too much pressure from a ventilator. Okay, so that can cause blunt trauma. So it's not always an outside force. Okay. Then penetrating, obviously that's pretty self-explanatory. Anything that's going to penetrate the chest wall. So knives, gunshots, right, any type of foreign object. Okay. So what happens with blunt trauma or chest trauma is we get things like fractures, dislocations, okay, the barotrauma, and definitely injuries to the diaphragm. Right, so we're going to talk about a couple of injuries that are caused by blunt trauma, and some of the most common ones would be like a sternal and rib fracture. Okay, so rib fractures if they're, depending on where they are, we really just have to manage the symptoms and look for complications. Unfortunately, there's not a lot you can do for a rib fracture, so we're just managing pain and making sure that they don't puncture something underneath. Okay, so we really want to think about the location of the rib fracture itself. If it's in the upper portion of the chest, we have to think about, having large vessels being severed, right? So this could be potentially fatal to our patient, right? The lower, they might injure some internal organs, so like spleen, liver. Okay, so we're going to basically do a lot of assessment for our patients and a lot of pain management. So for that flail chest, this is kind of like a really, really, really bad rib fracture. It's taking it one more step. Okay, so that flail chest is going to cause a paradoxical movement. So what that means is when 3 or more adjacent ribs get fractured at 2 different sites, that is actually what flail chest is defined as. So 3 or more adjacent ribs being fractured at 2 separate sites. So when this happens, the lungs can't fully exhale. So the lungs expand with inspiration and expiration, right? So that's going to lead to that paradoxical movement. So one's going in, one's going out, and they're not fully expanding. So this can lead to things like atelectasis, pneumonitis, and definitely respiratory failure. And we have to think about, these people are in severe pain as well, so not only can they not move that one particular lung in and out to get ventilation, but they're probably not moving air as well as they would be because they're in pain. Okay. So for pulmonary contusion, this is just damage to the lung tissue, usually resulting in hemorrhage and sometimes pulmonary edema. So this is really common with flail chest. So you have to think about those fractured ribs, puncturing some of our lung tissue. Okay, so bruising of the pulmonary. Right. So this slide just talks about some penetrating trauma. Right, so we're talking about gunshots and stab wounds being the most common. Usually our penetrating trauma is classified by the velocity of the weapon. And usually it's deceptive. So just because we have a gunshot wound to an area that we would consider non-fatal, that doesn't mean that it can't get worse. Okay? So we want to make sure that there's an entrance and an exit wound with these gunshots, because if there's not an exit wound, that bullet can travel throughout the body, causing worse problems. Okay, so complications from chest trauma. And remember, this is usually where we get most of our fatalities from, right? So all the complications that come after the chest trauma itself. First, we have the cardiac tamponade, right? So when we have those blunt injuries to the chest, this is going to compress our heart, right? It's going to compress that entire thoracic cage. So it's going to result in fluid and blood being left in the pericardial sac, and that leads to that cardiac tamponade, right? Cardiac contusion, is bruising of the heart, muscle, and tissue, right? Again, from the blunt trauma. And then, of course, increased thoracic pressure. So I talked about this a little bit with the vent lecture, right? So that, remember, this can be inside as well. So think barotrauma, too much pressure, too much positive pressure in our negative pressure system. Right? So all of these 3 things can cause cardiac failure. Because what's going to happen is it's going to lead to impaired ventilation and perfusion. And the right ventricle is most often included in this because it's the closest part to the lungs, right? So if that's responsible for pumping oxygenated blood in lungs, we're going to lose that our ventilation perfusion because our right ventricle is not working properly because it's being compressed. Right. So hypoxemia, hypovolemia, of course, obvious signs of trauma. We're not oxygenating our blood, so we're not getting good perfusion to our body. Hypovolemia from massive amounts of blood loss. Right. And then, of course, we have subcutaneous emphysema. Right. So if we have injured lungs, sometimes air can enter the tissue under the skin, like the neck and the chest area, and if you palpate, it causes like a crackling. Okay. So you learn this back in your respiratory assessment, right? So if you're palpating the lungs, that crackling is that subcutaneous emphysema. And that is all I have for part 2.